The side effect management of this class of agents, again, it requires the skill sets of someone who understands how to manage CRPC and certainly how to manage the side effects of AR inhibitors. As I said before, most of us in our busy practices have our supportive staff actually calling patients, talking to patients, and so forth. I think that the skin rash obviously is something that you may consider actually holding therapy and dose reducing, for instance, for apalutamide. Some people use topical steroids. I don't think I have ever used them. With hypothyroidism, again, it requires for you to actually check frequently for thyroid function testing to figure out if the patient is developing hypothyroidism or not. The neurocognitive issue is probably the biggest problem that we're having because we really underappreciate that side effect. We don't know how to follow those patients. And more important than that, when you look at the side effects, for instance, of just lack of testosterone alone and the impact of low testosterone levels in cognitive function is also real. So I think in the community, we underappreciate those side effects. And traditionally, what we tend to do is we hold therapy, for instance, with NSAIDs or apalutamide, and tend to dose reduce from 160 to 120 in the case of enzalutamide, sometimes even a second dose reduction to 80 milligrams. And the same would apply for apalutamide, when you look at the dose reduction data. Aramis, if you look at the drug discontinuation, the incidence of drug discontinuation just by side effects was probably in the 8 to 9%. So it's very low compared with the Spartan and Prosper data. You can dose reduce again, but I think that at least I participated in the phase 1 data with darolutamide, and the dose reductions that we have in those trials, again, probably echo and mimics what we have seen in the Aramis data. Lastly, if you look at the Aramis data quality of life report that Dr. Fisasi just recently published and presented at one of our national meetings, clearly the quality of life data is consistent with the side effect profile that has been reported with the agent. The unique, perhaps, difference between the Aramis and the other trials is obviously the fact that understanding the chemical structure of darolutamide allow the group who helped develop that Aramis trial to include and to feel comfortable including patients who were at risk for seizure activity. Obviously, we learned that the risk of seizure is real for enzalutamide and apalutamide. Again, clinically, I don't think that is the #1 priority in my mind when I select agents that can delay MFS and possibly even impact survival in a positive manner. I think you have to balance the trade-offs of that benefit against the side effects. I think that the quality of life and the neurocognitive dysfunction perhaps is the most important difference between Aramis, Spartan, and Prosper, recognizing that for the first time, those patients who were at risk for seizure activity were not excluded from trials, and therefore allows the Aramis data to have the safety signal in favor of those patients who were at risk for any reason or another. It does appear that the drug-drug interactions is a bit different with darolutamide when you compare with the other two agents. I think that most of our patients are taking many medications. Most people are hypertensive, diabetic, or are taking aspirin or what have you. And I think it's very important for us to minimize drug-drug interactions when we're thinking of starting these agents. So I think that one of the unique differences between the Aramis data as well is it appears that darolutamide has probably the least impact in those drug-drug interactions, although it does get metabolized through the CY pathway in the liver. So it's not that it doesn't have any interactions, it's just it appears to be lower mathematically compared with the other two class of agents. It's very hard to compare across trials, but it does appear that that's the case.